Thank you for your kind introduction, and also I'm very happy to join this wonderful APSCVIR meeting in Bangkok. And also I'm very happy to meet many friends, including the many young Thailand colleagues. In the next 80 minutes, I'd like to talk about treatment response evaluation and patient care after liver ablation. The key word of my talk is RCF. As we all know, Asia is the birthplace of local regional treatment. Thanks to the many Asian Society of Tumor Ablation Society members, we made the sound evidence on curative ablation with many papers, including the representative papers, self-study from Japan. As you can see, there was no significant difference even in recurrence-free survival between surgical resection and radiofrequency ablation. So I would say ablation is accepted as a curative treatment for early-stage HCC, including APSCVIR guideline and as well as Korean guideline. Again, ablation is the curative treatment option for early-stage HCC, even if surgically resectable. However, in most HCC guidelines, only tumor size and number are mentioned to assign the proper weapon. However, any weapon cannot guarantee the best patient outcome if we don't use accurately and smartly. Beyond the tumor size and tumor numbers, many more things should be considered for the best outcome. So I would say it is time to get a consensus on the strategic optimization for percutaneous ablation. Basic for the best outcomes, we have to consider careful selection, precise planning, accurate ablation, and finally post-ablation assessment. Imaging is essential for all these steps. Today, I will focus post-ablation assessment. The post-ablation assessment, treatment response evaluation, can be divided in three parts. First, intra-procedural assessment. Secondly, immediate post-ablation assessment. And finally, post-ablation follow-up and monitoring. Moving on the intra-procedural assessment, the close monitoring during the whole ablation procedure is very important. We have to check whether the ablation is optimal or excessive or insufficient. Close monitoring using the fusion or anatomy landmark is simple but very important. Close monitoring whether the pachyogenic zone is approaching to the planned ablation zone using the fusion marker. Overlapping ablation is not a good, not smart strategy because the zone window must be getting worse from the start of ablation. So if you recognize if there is any insufficient ablative margin at some area, it is inevitable to add overlapping ablation. One simple tip is reposition the applicator when the echogenic clouds will completely disappear. If you feel the ablation seems excessive, at the time, just immediately stop the ablation because safety should be considered first rather than complete ablation, because ablation should be minimally invasive. Moving on, immediate post-ablation assessment. Precise imaging assessment of therapeutic response and any complication is mandatory after ablation. CT or MRI play a critical role for assessing treatment response of HCC after local regional therapy. Interpretation is challenging because post-treatment imaging findings depend on the type of treatment, magnitude of treatment response, and the time interval after treatment, and other many factors. With immediate post-ablation imaging study, we should check if there is any residual, any complication, and also we can find any lesson from each case. Which modality? I think everybody in this room agree EOB MRI is the king of imaging modality. However, in real practice, many more operators prefer the dynamic CT as a routine follow-up. Also, we have to assess technical success first and then complication. It is effective of energy source. The ablation zone is changed, non-enhancing ablation zone with Rhim enhancement, reactive hyperemia. So this is the imaging history of HCC patient in our center last week. As you can see, the frequency of EOB MRI examination is continuously increasing because of the many benefits compared to CT. This is a typical ablation zone, immediate ablation zone with peri-ablation hyperemia, which is usually disappear over time. Take your time to evaluate post-ablation imaging three-dimensionally. Ablation size and configuration, whether it is optimal, excessive, or insufficient, or really residual. Depending on the status, we have to prepare ablation margin, circumferential versus eccentric, and finally, is there any immediate complication? If there is a definite residual on immediate post-ablation study, if technically feasible, we have to consider re-ablate. Otherwise, we have to refer to the case for radiation therapy. The technically feasible, just retry as a second session. So at least we have to achieve the complete ablation covering tumor itself. It is a marginal. And ablation margin sufficient or insufficient. Because of the microsatellite nodules, we have to achieve at least 5 to 10 millimeter ablation margin surrounding the index tumor. However, this kind of circumferential ablation margin is ideal, but as you know well, in our daily practice, many more ablation like this, eccentric ablation. That's the problem. But here's a question. For insufficient ablation margin, should we do additional ablation to achieve sufficient ablation margin? Yes or no? In my personal opinion, no. Because if we add re-ablate for all insufficient ablation margin, there is a possibility many more patients with insufficient ablation margin are probable to be overtreated because local tumor progression rate is about around 10%. So this is a reasonable option. Please wait and see, even for insufficient ablation margin. If LTP develop at the time, re-ablate. What about the complication? This is very important. Please remember very basic 3 facts. Please understand what is the broad spectrum of complication of the ablation. If we don't know this spectrum, we cannot detect complication, we cannot manage the complication. from immediate complication to delayed complication. At least, we have to avoid any mortality after this kind of a minimally invasive treatment by early detection as much as we can and proper management of any major complication. This is very easy but very important. Learn from each ablation. Always ask yourself, same to your planning. Compare the post-ablation result with your detailed plan and find the difference and think about the reason. And also please take your time to review your case with a self-Q&A session. Placement of electrode was really accurate. Ablation zone is similar to your plan. Was it excessive or insufficient? Why? Ablation margin, circumferential or effective? Why? Any mistake compared to your plan? What did you miss at the planning or procedure? How will you do if you have the same patient? So write down what you have done well and what you have done wrongly, and finally, what you have learned from that case. Please repeat your well done. Please don't repeat your first mistake. And finally, please share the lesson with your colleagues. So every way of ablation teach you some lesson. Finally, post-ablation follow-up. Most physicians prefer the 1 month follow-up CT. After that, every 3 to 4 months in 2 years. After 2 years, we can increase the follow-up interval to 6 months. This is at the moment the standard follow-up protocol. Normal contraction of ablation joint, we are calling the involution. The ablation joint is usually continuously contraction like that. It's a good example. The nice ablation joint covering the index tumor with circumferential ablation margin. The 1 year later, the ablation joint is contracted. This is a normal process. In this process, there is any mass-like enhancement in the ablation joint or adjacent to ablation joint, we can call local tumor progression. So this is the why we have to do regular follow-up imaging study. M-RECIST and LILAS is a more preferred method for response assessment. You can see that disappearance of any intratumoral arterial enhancement in the index tumor, we can call it complete response. LILAS provides criteria to categorize response of HCC to local regional treatment. RRTR include a non-evaluable, non-viable, equivocal, and finally viable. Recently, the LILA released the 2024 version, especially TLA. They have 2 cores, non-radiation TLA and new radiation TLA. The non-radiation based RRT include ablation and transarterial chemioembolization. And radiation based RRT include SBRT and Y9K. This is a new classification. And also, what is the imaging marker of viability? They more simply drive mass-like enhancement with any degree and with any phase. The quite simple. If there is any mass-like enhancement at any phase, any degree, we can suspect the local recurrence. This is the major change in 2024 version. And another change is ancillary feature. If the enhancement is equivocal at the time, you can perform the MR. If there is any two ancillary findings, diffusion restriction or heat to pipeline intensity, we can upgrade from equivocal to viable. This is another new change. You have to remember meso-like enhancement and ancillary two MR features. Finally, the viable, MR viable means any meso-like enhancement and or uncertain meso-like enhancement with ancillary T2 feature. Here is example, the meso-like enhancement adjacent to the RF ablation zone and the interval growth. Definitely we can say RRTR viable. And according to the category, if we can say MR and TL viable, we can discuss the treatment with multidisciplinary discussion. This is a new part, radiation TRA. This is a new part, radiation TRA. It is very hard to evaluate radiation-based treatment, but it took a long time compared to ablation. So they provide up to more than 6 months. The finding is very heterogeneous, then it's very difficult still. But please remember one new item, RRTR non-progressive or radiation-based TRA, define treated lesion with meso-like enhancement, which is stable or decreased size. This is a non-progressive. Today, I briefly introduce the treatment response evaluation and patient monitoring after ablation. The important thing is very basic. I believe all of you already know well, but sometimes we forget. If there is any residual, so we have to try to finally kill the residual tumor for second session. And also, don't miss the early finding of any kind of major complication. And finally, we have to learn at least one lesson from each case. And finally, I introduced the new LILAS TLA version, which was released this April. Please remember, meso-like enhancement with any phase, any degree. So maybe now you can figure it out. What does it mean? R and C, and finally L. Thank you for your attention. Thank you very much.
Thank you for observing. So I always enjoy your presentation. Very beautiful presentation as always. So I think we have 2 minutes left for open for all of you to have a Q&A session.